Great. As you guys have just witnessed, I am not the most Zoom savvy person, so bear with me here. But for those of you who I don't know, my name is Celia Haering. I'm one of the R2s. I'm also in the clinician educator pathway, and I'm excited to talk to you guys today about diagnostic reasoning. I suspect we will be done in time for the interns to make it off to their conference. So initially I was going to try to talk about clinical reasoning today. I was like, I'm going to teach them all about clinical reasoning because we don't do this very formally in residency. And as it turns out, nobody really knows what clinical reasoning is. That's like a huge field, and there are many papers literally just written about nobody knows what clinical reasoning is or how to define that, or sort of how to draw the bounds around that. And so I kind of ended up further and further into the weeds of those corners and settled on, we're going to try to talk a little bit about just sort of broadly like diagnostic reasoning and sort of some of the more accepted models for how we diagnostically reason. And this, I think, for me is really, as I sort of alluded to a little bit, based on the fact that I feel like my medical school talked quite a bit about this. And then in residency, I think we kind of allude to these things periodically, and we like talk about problem representations at morning report sometimes. But I'm not sure that we have like a uniform background in sort of what some of this terminology is and like exactly what it is that we're thinking about and talking about. And so that's really my goal for today, is just to kind of get that like basic background for everyone. So the instructions said to include disclosures slide, and I don't have any disclosures, but when I was writing, I'm just a resident. I don't know if you guys recall this song from Winnie the Pooh, like I'm just a little black cloud. It's pretty much all I could think about. And it was otherwise just a big empty slide. So anyway, there's Winnie the Pooh being a little black cloud. And similar to, what Cooper said, I think like the other part of this being, obviously nobody pays me except UW, but also I just have spent some time in the corners of the internet reading about this, but you all also have your set of experiences to draw from. So please feel free to jump in and ask questions or add comments. Or I think we'll have some time at the end if anybody has them there too. So our objectives for today are namely to, consider the concept of dual process thinking as it relates to the evaluation of patients. And this is a model that I'm guessing that many of you have heard of, probably in the context of medicine, but we're going to just sort of go back over that. Understand how like the role of a problem representation and how having dynamic problem representations guides our evaluations, review some of the common heuristics in medicine and how those can become heuristic traps or cognitive errors, and then just try to spend a few minutes kind of thinking about like the inherent uncertainty that exists in diagnostic reasoning and medicine, and sort of how that in particular might come to rest on us as trainees. So this is sort of similarly just an overview of the day. The only thing I'll say is that I have one slide about avalanches, because for those of you who know me, I cannot make it through a whole talk without going on some sort of a tangent. So we'll spend a few minutes there, but other than that, really just kind of as I already said. So let's jump in to thinking about dual process thinking. So dual process thinking, some of you may have read the book, I think it's called like Thinking Fast, Slow, or Thinking Slow, Fast, something like that. It's basically this idea that came out of kind of like psychological research mostly. And this is where that like type 1 or system 1 thinking, type 2, system 2 thinking comes from. And it is generally accepted by many people who spend a lot of time thinking about clinical reasoning or diagnostic reasoning that this is probably, this like messy graph here is probably a reasonable model for us all to try to share in when we are thinking about how it is that we think or how that we reach diagnoses. So basically, we'll get to sort of why I felt compelled to include this whole messy graph later, but to like distill it, you meet a patient who has some sort of an illness presentation, and basically either you recognize that and you're like, oh yes, this is somebody in a heart failure exacerbation. I've seen this a million times before. I know exactly what this is. And you activate your type 1 thinking, which is that sort of unconscious, like fast thinking, and you've already reached your diagnosis. Or you see this patient, and maybe this is what happened when you were for us, like when your first day of third year of medical school, you met a patient and you had no idea what was going on with them. And they were also having a heart failure exacerbation. But at the time, you just didn't have, like, you hadn't developed that type 1 thinking for that problem. And so that's when you activate that more like types 2 slow thinking and sort of going through your analytic processes to try to figure out exactly what it is that's happening with the patient. And you might be sort of digging more into like trying to use your Bayesian reasoning of like, what are the most likely probabilistic models of what's happening here. And then all of this is basically to say that sometimes when you meet patients, you are bouncing back and forth between the two. You think you know what's happening, and then you get a piece of data that doesn't fit. And you kind of have to stop and back up, and you might go back to your type 2 thinking and say, like, what's going on? Why doesn't this fit? How can I, like readapt my model or sort of test this out differently to make it fit again? And then eventually you might be able to bump back over to that type 1 thinking. And the hope is that those sort of system 2 thinkings, that as you see more and more patients, right, as you go through your third year of medical school and you see patients with heart failure exacerbations over and over again, that becomes something that you can recognize in your type 1 model. And so this picture over here kind of on the right is just basically another, like an older representation of this, and just sort of to say that this is a process that's happening actively as we're talking to patients from the very beginning, that we're like creating a problem representation, which we'll get to in a minute, which is sort of our conceptualization of what's going on with that patient. And we're testing that against what we like, the diagnosis that we think applies to the situation. And then, if that fits, we're happy we've landed on our diagnosis. And if it doesn't, we're going back into that like data acquisition phase and sort of looking for more, maybe talking to them, maybe getting more labs or x-rays or whatever. And that all of this is happening within sort of our specific knowledge and context setting and like what we already know. And so like that part is probably, are you a third year medical student, or are you now one of our excellent R3s, Dr. Kersey, who's about to go be a cardiologist? Like, how easy is it for you to recognize these heart failure exacerbations? Okay, so this is something that I think that we, like at Morning Report, we regularly say, okay, who can come up with a problem representation? And I think that I used to get sort of annoyed with like people, we would get caught up in the details of like, what is the difference between acute and subacute and hyperacute? And then do we use the age, or do we call them elderly versus middle-aged, right? And so I thought that we could spend just a minute, because I think like you guys are all experts in making problem representations. I think we can spend just kind of a minute talking about like what goes into a problem representation. But I think that really the more interesting part is thinking about why we are using these problem representations. And in the end, it probably doesn't matter too much whether you call them 62 or you call them middle-aged or you call them elderly, as long as like it matches with sort of your conceptualization of what happens to 62-year-olds or elderly people or middle-aged people. So just to sort of go through the things that we think belong in problem representations, there probably should be a time component, which is that sort of acute, subacute, chronic structure is the one that you guys are probably familiar with. Some sort of like modifier on the temporality. So is it constant, or is it progressive, or is it intermittent? Some sort of location. Obviously, it's hard to know what's going on with somebody if you have no idea where it's happening. And then I think that this is a piece that we sort of sometimes is really like a key component of kind of early clinical training, is learning to name these syndromes and learning to figure out when to call it a syndrome, or when to even then call it a diagnosis, as opposed to sort of using those initial presenting symptoms over and over again. So I think this is something that, like with medical students, I frequently see where, the patient's chief complaint was shortness of breath. And 4 days into their presentation, the medical student is still telling you every day on rounds that this is somebody who you admitted with shortness of breath. And at some point you're like, I'm so tired of you telling me this person came in with shortness of breath. Just tell me they came with a heart failure exacerbation. And there's probably an intermediary step in our thinking, right, between they have shortness of breath and they have a heart failure exacerbation, which might be like volume overload, right? A syndrome, and you don't know yet why they have volume overload, but you can sort of see enough pieces of the puzzle coming together that that's what's clearly what's going on with this person. And then I think similarly, I capitalized pertinent here because this is something that is like one of my pet peeves when folks are writing out their problem representations or their one-liners for patients, is including only the pertinent epidemiology. So I think that we sometimes have this tendency to say that somebody has a, put in the one-liner that they have hypertension, they have diabetes, they have OSA, they have untreated anxiety and PTSD and every other problem that they've ever been told that they had in their entire life. And the point of a problem representation is to be really framing how we are thinking about a patient as it pertains to like the problem at hand, right? The problem representation. And so if these things are not relevant and they're not driving your thinking about what's going on with this patient, they probably don't really belong in that one-liner. And I think that like oftentimes you can justify that something does or doesn't belong, and that's fine as long as you can justify what's there. It probably belongs, but it's probably not always necessary to include the entire laundry list of problems in that problem representation. And then, sorry, processing, I guess, is a word that that is kind of key here that I didn't actually define. Processing is basically just this, like our ability to do this, to take what the patient's telling us, take their story and translate it into these terms that we're all familiar with. And people have actually studied this. They've taken like groups of medical students. They actually did this awesome study where they had the medical students, small group leaders pick out like the worst medical students and the best medical students. And then they took some doctors and they gave them all like a patient history in the patient's words and asked them basically to process it, to like develop essentially problem representations out of it. And what they found was that basically the sort of more advanced the clinicians, the more of these terms, the more of these semantic terms, like acute and intermittent and migratory, that was associated with your sort of level of clinicianness, as well as with being more likely to pick the correct diagnosis for those patients. And so I think this is really like why we spend so much time thinking about and talking about problem representations, is because we think that that's so important to our mental model of what's going on with people. So let's jump from there sort of into system one thinking or type one thinking. And, in my mind, like if a problem representation is specific to a patient and is a framing of exactly what's going on with that patient, then an illness script is really like specific to a syndrome or specific to a problem, and is sort of like you're trying to match up your illness script for a diagnosis with your problem representation. But that said, your illness scripts in general are broad because these are things that we're building out over time. This chart here, sorry, I guess I'm realizing in this view, I can't make things pop up as I was going to, but I think when I was a third year medical student, somebody must have given me some sort of assignment that I had to like make this illness script grid for something, because I remember very specifically hating having to make these illness script grids, but they would occasionally make us turn them in as homework. So I think it was when I was on my OB rotation, they told us we had to do this. And I actually dug this out of like my Google Drive because I was like, oh, I remember that I had to do these things once upon a time. But basically, I think this is how like we're trying to teach medical students about illness scripts these days, is sort of in these grids where for each differential diagnosis that you're considering, you should be thinking about and developing out over time sort of what goes into each of these categories of like predisposing factors, or which might be kind of your pertinent epidemiology, and then like the clinical presentation and the time course, and sort of like what are each of those semantics going to be, so that you can begin to try to match those illness scripts up with your problem representations. Sorry, I'm just seeing what Jordan said over here. Yeah, totally. I think, Jordan, you're hitting this on the head with like sometimes we don't really know what's going on. And so I think that as we like as we develop a more confident understanding of what's happening with the patient, we can begin to sort of hammer in on these diagnoses or like specifically address them. Sorry, I think somebody started power washing outside my window. Is it like super loud for you guys?
It's okay.
It's okay.
Yeah.
Okay. So that's, I think, what I have to say about like illness scripts. And then I think, you know, conversely, if your illness scripts are failing you and you are trying to activate your type 2 or system 2 thinking, that's when you get to thinking about diagnostic schemas. And I'm not going to go through these specific diagnostic schemas. I think that we all know that basically it's probably important to have an approach for a problem. And it probably doesn't matter too much what that approach is. I think everybody kind of has their preferred ways, and many people who spend a lot of time listening to podcasts probably like have some of these overlapping favorites, like the Misto that everybody likes to use for altered mental status. If you don't have a problem specific approach, just having something to fall back to, be it like one of these Vindicate acronyms or like an anatomic approach, just having some way to go back into that analytic type 2 thinking and make sure that you're kind of not missing anything is really the point here. Okay, so now I get to go on my tangent about avalanches. Some of you have probably taken avalanche classes. Some of you may in fact know that there's a whole snow science and avalanche science like area, field of research. They used to have meetings at my university almost every winter. They would do these international snow science workshops there when I was in college. So I feel like I got to spend a lot of time hanging out with snow scientists. Like all my classmates in college were doing their snow science degrees. So anyway, we spent a lot of time thinking about this or talking about this when I was in college. And basically, you know, people sort of like, avalanches are scary. This picture over here on the left is actually a place in Alaska. This is like one of my favorite places to go skiing. I know, right? Right, Thomas? Sometimes I think I made the wrong choice in life. This place is called Eddies, and this is like the classic, like it's a storm day, high avalanche risk, we should go skiing at Eddies because it'll be safe there place. And so like this is the sort of skin track here that you take to get up the hill, and then once you get up here you turn and you ski down. And you can see this guy, this was earlier this winter, was skiing up this hill, and he got someplace up here, triggered this avalanche, the whole slope went sliding away. And he thankfully was okay. He did not get caught, or he didn't get buried in the avalanche. He just sort of got spit out right here. But like avalanches are horrifying. They kill people every winter. And so probably like 20 or 30 years ago, people were trying to figure out like, okay, we're pretty good at snow science. Like we understand how snow plasticity works. And we teach in our avalanche classes, there's sort of these three main tenets. Like we teach how to pick safe terrain, we teach how to analyze the snowpack, and we teach like how is the weather going to affect our choices. And yet in spite of all this stuff, we have a bunch of like top-notch snow science avalanche experts who go out and get caught in avalanches and die every year. And so like, what are we missing? Because like we know what's going on with the snow and with the terrain. So why do people keep dying? And so this was some guy's master's thesis. He basically analyzed like 100 avalanche accidents and tried to figure out what had happened. And his basic conclusion was that what was missing was the human factor. So like the way that people are making decisions. And these people, they have the information, the knowledge base available to them. And so like, why are they still making decisions where they end up in a really dangerous, scary place? And so now, if you take an avalanche class, most avalanche classes will include like a significant component about talking about the human factors of like going outside and interacting with avalanche terrain. And there's basically in the avalanche world sort of these like 6 main heuristics that they talk about that I think are not super important for us to go into the specifics of today. But like when I took my avalanche class, you filled out a journal. Every time you went outside, you would go through each one of these heuristics and think about how might this be impacting my decision-making today? And how can I specifically address that to try to like make this a safer day for me to go outside? So I think like the reason that this avalanche in particular speaks to me is because of this familiarity factor, where like this location feels very familiar and very safe to me because I've been there so many times that even on a dangerous day, it feels like a safe place to go. When it turns out that probably that's wrong, because like that's how this guy got caught in an avalanche. And so I think like these heuristics and being aware of how we're thinking is something that in the outdoor literature and like risk management is such a huge piece of things. And so it was always a little bit surprising to me then that in medicine it felt like we thought that if we could just learn all of the medicine in the world, if we could just memorize all of up to date, that like we would be okay and we would make the right decisions. And turns out that's like definitely not the case. So coming back to this ugly chart or graphic that I had included early on, the reason I wanted to include this one in particular is really because it's got these sort of the dotted line boxes, which I think are the interesting, like these are where they're trying to include that even if we have excellent illness scripts in our minds and we have excellent diagnostic schemas, we still have to actually go through that process of making the decisions. And there are going to be all sorts of sort of external factors to our knowledge base that are going to influence our ability to make those decisions well. And so I think that at least in this graphic, those kind of heuristic traps and cognitive biases are what they're trying to encompass in this like hard wiring, whatever that's actually supposed to mean up here. And so I thought that we could spend just a minute going through some of the most common heuristics that we encounter in medicine, because I think that these kind of come up repeatedly. And again, I'm not sure how universally they are covered in medical school curriculums. And just to say that heuristics, so like we think that type 1, system 1 thinking in itself is the use of heuristics. And heuristics themselves, we don't think are like bad or problematic. Heuristics are just these mental shortcuts that we take. And so like the use of an illness script to match up with a problem representation and get us to a diagnosis quickly, like that's a heuristic, and that's probably not necessarily bad. But when we take them too far is when we sort of get into them becoming these heuristic traps or becoming cognitive biases. And so people have tried to study like how much of diagnostic error is attributable to cognitive errors or heuristics. And as it turns out, this is a really difficult thing to study. Somebody did this study, I think it was like 2005 or so, where they basically took 100 cases. Some of them were identified at time of autopsy and sort of matching autopsy to like diagnoses that had been listed and finding discrepancies there. Others were identified by physicians who felt that they had missed something. But basically these were 100 cases where the diagnosis was either delayed or had like never correctly been landed on. And they went through each of these cases and tried to figure out how often was this happening because of a cognitive error. And their basic conclusion was that in like 75% of these, there was a cognitive error, which is huge, right? Like if that's the case, if 75% of the time that we're going wrong, it's at least in part because of cognitive error, then it feels like we should probably be spending more time talking about this and talking about these heuristics and how they might be tripping us up. Somebody did another study a few years later. Here, they took 37 doctors, they gave them 8 cases, and in each of the cases, there were basically 2 diagnoses that just sort of based on the case prompt could be relatively, like it could be either or. And then they finished the case by having it be one or having it be the other. And meanwhile, like the doctor in the case had made a choice. And so half the time the doctor had made the right choice, half the time the doctor had made the wrong choice. And they asked them at the end, like, did a bias come into play here? And if so, which bias? And what they found was that these doctors who were doing the cases, evaluating the cases, were about twice as likely to believe that there had been bias if there was a negative outcome, if they had like reached the wrong conclusion, than with the same case, but the doctor had reached the right conclusion. And that when they were asked to identify which biases had come into play, that there was essentially no congruency. I think they had six biases to choose between to sort of specify like what was done wrong here, which cognitive error was at play. And there was essentially no agreement between them. And so I think this really just is kind of highlighting the difficulty of taking any real life scenario and being able to determine, like, was a bias at play here, or was it just a useful use of these heuristics that we all employ all the time. Okay, so getting into some of these heuristics that we think are quite common in medicine that I think are sort of worth mentioning. The first one that we'll mention is anchoring. And these three I have on this slide because I think that they're closely related, but they're a little bit distinct. And so I want to make sure that we kind of try to clarify that. But the idea with anchoring is basically that we're prone to taking something like picking one element of a patient's presentation early on and fixating on that and forgetting to sort of rebroaden as like other features come up. And so if somebody might come in with leg swelling and then the next day they're in respiratory distress, but we're still fixated on trying to figure out what's wrong with their leg swelling, probably we're not in the right place. Premature closure is more like arriving at a diagnosis, and then even though more information is coming up that's not congruent with that diagnosis, failing to rebroaden our differential and sort of go back to the drawing board, or like failing to then bump down to our type 2 thinking perhaps. And then confirmation bias is really like taking the diagnosis that we already have and just continuing to look for further evidence that's supporting that, as opposed to like looking for evidence to prove ourselves wrong, basically. Does anyone have any questions about the differences between these three? Because I think there are three that are like so close together that I have often struggled with telling them apart. Okay, I think we're good. And then I think these are the only other three, and I'm not going to like belabor this too much with you guys, but the other three that I'll mention today are availability bias. This one is actually interesting because this one is, there have been multiple studies done that have been able to demonstrate basically that that like in a prospective way, we do this, we use availability bias, like trainees in medicine. And so, people have been given cases that had a particular diagnosis. And then if you keep giving them cases, people will be more likely to choose that same diagnosis over again, as opposed to like looking for a different diagnosis. And in some ways, right, you can see how this is useful because like common things are common. And if you see something recently, it's probably because it's common. On the other hand, if we're forgetting to look elsewhere because we think that now everybody has heart failure, then it's not going to work. The commission bias, this is one that I was less familiar with and I found pretty interesting. I think that this is something that to me felt like something that I tend to do perhaps in like the emergency room or clinic setting. It's basically this tendency towards wanting to do something and like not wanting to do nothing, which is based in our wanting to be helpful, right? To help our patients. But I think we all know that sometimes our well-intended actions have not so beneficial side effects. And so sometimes probably doing nothing was the right move, but because we are so, because we want to do something, sometimes we just tend to do more. And then the authority bias, those of you who know me well will know this is another of my favorites, is just this idea that we tend to defer to authority, and that if our attendings say something, that we might tend to take that as truth, whether it be correct or not. And so I think remembering, and I think that this is where this is like the whole basis of that CUS, I think it's called CUS campaign, where it's like, I'm concerned, something, whatever, like the idea that anybody should be able to speak up at any time and say that they have concerns about what's happening at that point. Let me see. Priyanka. Yes, there is. I'm just reading Priyanka's question. Is there a name for overestimating likelihood of prior misdiagnosis or negative outcomes? There is, and I don't recall right now off the top of my head what it is. There's like, if you look in the internet, I mean, there's people keep these lists of like, you know, people will say that there's anywhere between like 70 and 100 different like cognitive errors or heuristics that we employ in medicine frequently. And there's like databases of these. And it's actually really interesting. Some people have these, there's some, you can see these, they've been put on wheels, and you can see how like some of them directly contradict each other. So like with the commission bias, there's an omission bias, which is the like direct opposite, which is the tendency to want to do nothing. And so for most of these, like if you take anything to an extreme, right, if you take it from one side back to the other, like you're not doing yourself any favors there either. And I'm just reading what Kim said. Labs aren't perfect. Yeah, totally. I agree, Kim. Sometimes we don't know what's going on. So I think that kind of gets to this next piece is like, what if we don't know what's going on? What if our type 1 thinking has failed us? We have no idea. And somebody actually, so it's really hard to study like how often these cognitive errors, these heuristic traps are coming into play. And I think there is another kind of like corner of clinical education research where people believe that probably this is way overplayed because it's been studied that like you can teach people to identify these heuristics. You can teach them to like in case-based scenarios, say which ones are happening, but we have not been able to demonstrate in any meaningful way that you can, by teaching people these heuristics, actually improve their like diagnostic yield or their diagnostic reasoning. So I think a lot of people think that perhaps this aspect of things is overplayed, and that really like what a lot of this comes down to for trainees in particular is that if your type 1 thinking is not working and you're trying to use your type 2 systems, but you just don't know, then like you can't arrive at the answer, right? You're never going to be able to diagnose someone with a problem that you've literally never heard of before. If they have some sort of rare rheumatologic disease or something, I don't know anything about rheumatology. I'm literally never going to diagnose anyone with a rare rheumatologic disease. And so I think that gets to like the kind of errors that we run into or the limitations that we run into when we're trying to use our type 2 thinking or system 2 thinking, which are going to be a combination of just straight up knowledge gaps and then basically bad reasoning. And so I want to just acknowledge that I think the other things that tend to oftentimes in particular affect us as trainees are like things that lead to bad thinking. And I think that it's interesting, like when I've talked about this topic with friends in other fields, like if you talk about this with a pilots are like, yeah, this is stupid. Like, why are you even thinking about this or talking about this? Of course, literally everything in your life is going to affect your ability to make decisions. And this is why, like, as pilots, we're not allowed, we have like such strict limitations on the number of hours that we're allowed to work for at a time. If you get stuck on the tarmac for too long, they're going to have to switch your pilot out because they like don't think that it's reasonable for pilots to work that long at a time. Because we know that all of these things, being tired, being hungry, having other things going on in our lives, and all of these background experiences are also going to inform the way that we make decisions and inform the way that we are able to use those diagnostic schemas and as well as to develop those illness scripts. And I want to just take this moment to acknowledge, like along with this, I think a lot of these kind of unconscious biases that we spend so much time thinking about falls into right here. And that when we think that like using type 1 thinking and using heuristics is a really useful mental shortcut, the danger of that, as we've said sort of explicitly with cognitive errors and with heuristic traps, is that we are we're like explicitly allowing these biases we have to inform our thinking. And there's a lot of problematic aspects to that, I think. So I think this kind of gets a little bit to Kim's point, is like, what do we do when we don't know what's happening? And when I was preparing this talk, or when I was thinking about this talk, I was talking with Dr. John Ilgen, who's one of the emergency department doctors, who does a lot of thinking about clinical reasoning. I think he's sort of one of our UW experts in the area. And this is something that I think, particular for him being in the emergency department and sort of being based early on in patients' courses, where oftentimes our ED colleagues don't know what's happening, is something that he really has spent a lot of time thinking about. And I think just like wrapped up a PhD in or something, is basically this like space for uncertainty. And so what he really encouraged me to include this slide, particularly talking to residents, with sort of the idea that like, probably as people who have more of those knowledge gaps, we spend more time in uncertainty. And so what he advocates is that basically, if you don't know what's wrong, right? Kim, if somebody is here with shortness of breath and they might have a heart failure exacerbation, they might have COPD exacerbation, or they might have CAP, like, what do? We treat them for all of them, right? We just kind of try to keep them safe. Or if the real problem is that they're in respiratory distress, we manage their respiratory distress first, and we kind of figure the rest out later, right? And I think then, phone a friend. And this is like something I think it's good for us to keep in mind. I'm always sometimes shocked when I rotate on our elective subspecialty services by some of the consults that we might get from other services in the hospital. And I think like remembering that when a consult is being called, that it's because somebody else has run up against sort of their limitations. They've run into this space where they know that they're not doing their best thinking, or that like they're not able to make the best decision for this patient because either they're too tired, there's a gap in their knowledge, they're employing some sort of bias. But like the important part is that they can tell that there is something going on here that they can't deal with themselves. And so they're asking for our help. And then we get to do that too. And sometimes I think that rotating on those subspecialty services reminds me that probably I should do that more. And sort of remember that like when I'm running into trouble, there's always somebody, be it my attending or a subspecialist or whoever, that I can call. Sometimes, I think we've all experienced this, that we'll take care of patients in the hospital for days or weeks on end, sort of doing these like syndromic treatments and taking care of what we know how to take care of, and we still don't really understand what's going on with them. And it just takes time for these things to declare themselves. And that can be a really hard space for us to be in, to feel like we don't know how to help our patients because we don't understand what's driving their processes. And so I think that's kind of this piece where like just having a lot of compassion for ourselves, and also remembering that this might in particular be a more difficult space for sort of earlier trainees, for like our medical students and kind of younger trainees to be in, and that they might use a little bit of extra sort of acknowledgement that like we are doing our best here and there are limitations to what we can do. And then going back later, so if you rotate off service, or if you are taking care of a patient in the emergency department who you hand off and there's not really a clear resolution yet. If you guys know who Gurpreet Dhaliwal is, he sort of has all of these talks on the internet that are basically based around the belief that like we could all become expert clinicians if we were to follow up on every patient we ever saw and find out what actually ended up being the case with them much later on than when we saw them, and sort of go back and figure out like, when I saw them, how did that match up with what their broader presentation ended up being? And how could I possibly have sort of like intervened or figured this out earlier? Okay, that's basically all I have. I just was gonna acknowledge Dr. Ilgen because he was super helpful to me in this. And then these were kind of some of the more interesting readings that I came across, or references. And then any other questions out there or comments from folks? You're great, Kim.
I was just going to say, I think one thing that I think is interesting in clinical reasoning and why I'm interested in like debriefing and why you've like made me, you probably listened to me talk about debriefing is I think part of like a unhealthy response to an adverse outcome is to then like let that impact your clinical reasoning moving forward to like not that make mistake again as a way to like try and process the trauma of making that mistake originally. And I don't, it like doesn't fit well into like one of the biases, but I think it's like a specific pathological type of sort of recall bias where you particularly recall like bad events that happened and then like over correct for them in future cases, that I think is interesting.
Yeah, agree. I think that like, I mean, and I think that like that kind of just speaks to that part where like we're really bothered by things that don't go the way that we want them to, right? Or like if we feel like we haven't done the best or that we haven't gotten there fast enough, like we, I think, tend to take that personally and feel like that's been like a personal failure, you know, to your point about, I think, your sessions that you've been developing for us, like figuring out how to separate that from like medicine is hard and not everything shows up exactly the way that you wanted it to in the textbook.
I think the hard thing too is just like, you know, we can learn all these illness scripts and treatments and things like that, but it's so hard to learn how to think. And it's like you can't, it's a really hard thing to teach, and it's really hard thing to like intentionally do every time. And I don't know. I just find that this is super difficult and appreciate all your thoughts about it.
All right. Well, with that, thank you so much, Celia.